The human thorax operates as a highly volatile negative pressure engine. It constantly contracts and expands, generating immense mechanical tension to drive respiration. Memorizing static anatomical structures will not prepare you for the operating room. Mastering this space requires translating textbook anatomy into dynamic fluid mechanics and surgical strategy. To navigate this complexity, we divide the chest into 4 distinct clinical domains. These are the airway and oncology space, the pleural pressures, the structural chest wall, and extremist trauma protocols. Every surgical intervention in the chest relies on a single principle. You are applying mechanical corrections to physiological failures. The structural layout of the bronchial tree dictates clinical vulnerability. The right main bronchus branches off at a steeper, more vertical angle than the left, and it is noticeably shorter and wider. Because of this geometry, the right lung offers the path of least resistance. Inhaled foreign bodies and aspirated fluids routinely travel down the right side, directly localizing aspiration pneumonia. When addressing lung neoplasms, the initial tissue pathology dictates the entire management pathway. Small cell lung cancer metastasizes early and relies on chemotherapy, while non-small cell lung cancer is evaluated immediately for local surgical resection. The diagnostic sequence starts with structural imaging via a CT scan. Suspect lesions are then evaluated with a PET scan to identify highly metabolic, FDG-avid tissue. This CT scan shows a large mediastinal mass compressing the central airway. Imaging identifies these central tumors, but you must evaluate the surrounding mediastinal lymph nodes to establish an accurate clinical stage. To secure a tissue diagnosis, surgeons use targeted invasive tools. Flexible bronchoscopy visualizes the segmental airways, while endobronchial ultrasound and mediastinoscopy sample the adjacent lymph node stations. The resulting TNM stage determines the limits of surgical intervention. A T1 node-negative tumor qualifies for a curative anatomical resection, while higher stage nodal involvement moves the patient strictly into palliative oncology. Operating on the lung introduces a direct physiological threat. Excising malignant tissue inherently removes functional pulmonary segments, immediately reducing the patient's respiratory reserve. Clinicians use the British Thoracic Society tripartite risk assessment to evaluate 3 vulnerabilities. First, operative mortality via thoracoscore. Second, cardiovascular risk, excluding surgery within 30 days of a myocardial infarction. Third, post-operative dyspnea, calculating predicted FEV1 by subtracting resected segments from total lung volume. If a patient registers as moderate to high risk during this calculation, further testing is required. A cardiopulmonary exercise testing result above 15 milliliters per kilogram per minute serves as the mandatory physiological cutoff for surgery. Once cleared, the physical execution relies on established anatomical boundaries. The standard treatment for early-stage non-small cell lung cancer remains a complete lobectomy, isolating and ligating the lobe-specific artery, vein, and bronchus. Surgeons increasingly avoid traditional rib-spreading thoracotomies. Minimally invasive approaches, like robotically assisted thoracic surgery, preserve chest wall structural integrity and reduce post-operative recovery time. Securing clear tumor margins is secondary to respiratory physics. Surgical candidacy is a strict mathematical calculation, ensuring the patient possesses enough functional alveolar mechanics to breathe off the ventilator. The pleural space exists as a potential space between the lung and chest wall, maintained by a continuous turnover of fluid. The environment operates on Starling forces. Hydrostatic pressure pushes fluid out, while oncotic pressure pulls it back. Combined with the lung's natural elastic recoil pulling against the chest wall, the system maintains a precise net drying effect of exactly 6 millimeters of mercury. A pneumothorax represents a catastrophic breach of this vacuum. Primary spontaneous cases typically occur when an apical bleb ruptures in a young, healthy patient, whereas secondary cases involve visceral leaks caused by underlying conditions like emphysema. To restore the negative pressure vacuum, surgeons insert a small-bore Seldinger-type chest drain to evacuate the accumulated air. Insertion strictly follows topographical landmarks known as the triangle of safety. This area is bordered anteriorly by the mid-axillary line, inferiorly by the level of the nipple, and laterally by the pectoralis major. The anatomical rule for this procedure is absolute. The drain must pass directly over the superior edge of the rib to avoid severing the neurovascular bundle that runs along the inferior margin. Managing the pleural space relies entirely on biological plumbing. Re-expanding the lung requires restoring precise fluid pressure gradients without causing iatrogenic hemorrhage. When bacteria from an underlying pneumonia breach the pleura, they trigger an empyema. This infection evolves through 3 predictable worsening phases. It begins with the exudantiase. The protein-rich pleural fluid remains free-flowing, meaning it can often be cleared with targeted antibiotics and simple aspiration. Over subsequent days, the infection advances into the fibrinopurulin phase. The fluid thickens and loculates into separate pockets, mandating mechanical debridement using video-assisted thoracoscopic surgery. If left untreated, the fluid hardens in the organizing phase. A thick, fibrous peel forms over the visceral pleura, physically trapping the lung and rendering standard chest drains useless. Liberating the lung requires an open decortication. The surgeon must manually dissect and strip away the hardened parietal and visceral cortex without tearing the fragile lung tissue underneath. Pleural infection degrades tissue elasticity. When fluid hardens into a rigid cage, medical treatments fail, leaving physical stripping as the only mechanism to restore respiration. The boundaries containing this pressure engine are prone to structural failure. The diaphragm has 2 congenital weak points where abdominal viscera can herniate: the posterior foramen of Bachdalek and the anterior foramen of Morgagni. The transverse colon frequently pushes upward here, compromising thoracic volume. Even without a physical tear, the diaphragm can fail through innervation loss. Diaphragmatic paralysis elevates the flaccid muscle, reducing lung capacity. Surgeons correct this by placating the diaphragm, physically suturing it into a lower position to artificially expand the thoracic cavity. At the superior border, the thoracic inlet faces its own anatomical crowding. The presence of a fibrous cervical rib originating from C7 creates thoracic outlet syndrome. This extra rib presents a dual mechanical threat. It can compress the T1 nerve root, causing muscle wasting in the hand, or it can crush the subclavian artery, promoting dangerous thrombus formation. On the anterior chest wall, a depressed sternum characterizes pectus excavatum. This inward dish-shaped deformity directly compresses the heart and lungs, restricting cardiopulmonary expansion. Surgeons repair this using an open ravage procedure to reset cartilage, or the minimally invasive Nuss procedure, sliding a curved metal bar directly behind the sternum. This postoperative radiograph shows the Nuss bar in place. The metal brace physically forces the sternum outward, remodeling the chest wall over several years to restore normal thoracic volume. When external violence shatters the thoracic boundaries, the surgical response shifts completely. All blunt and penetrating trauma requires immediate adherence to strict advanced trauma life support algorithms. In the resuscitation bay, there are 3 indications for an emergency room thoracotomy: massive hemothorax, suspected cardiac tamponade, or a witnessed cardiac arrest. When those criteria are met, the left anterior thoracotomy is the standard approach, tracing a rapid, curved incision across the intercostal spaces. This specific angle bypasses thick muscle and bone, eliminating the need for specialized orthopedic tools. It provides instant access to the pericardium and can be quickly extended across the sternum into a bilateral clamshell incision. In an extremist scenario, precision yields to rapid decompression. The emergency thoracotomy serves as a blunt physiological reset, prioritizing immediate access to the heart over anatomical elegance. Every compartment in the chest operates as part of a single, unforgiving ecosystem. A failure in one quadrant immediately destabilizes the whole. You cannot resect a tumor without mathematically accounting for the loss of forced expiratory volume. You cannot drain air from the pleura without precisely tracking the neurovascular bundle. And you cannot repair a hernia without understanding the pressure differentials you are disrupting. Whether the threat is an invasive neoplasm, a loculated infection, or a penetrating blade, thoracic pathology manifests as a breakdown of spatial boundaries and pressure physics. Every procedure in this space translates the principles of fluid dynamics and structural engineering into the mechanics of human survival.